insular cortex, are all light up generally in people that have pain problems, and so they did cluster headache. So imaging's been, I think, good to the disorder because there's something concrete about being able to see a real-time picture of what's going on in the attack to be able to firm up our ideas about it. I think a lot more needs to be done in imaging. It's been difficult because it's just imaging's, I don't want to bleed on the same subject, but imaging's expensive. To do this kind of functional imaging with PET, you've got to have the right technology, the cyclotrons and the scanners and so forth. And ideally one would do a lot more of it. There's a lot more to be done. But it's just difficult. It's a little difficult to. It's been a bit difficult to convince various people that's a very good idea. We'll talk about therapies for a little while because they're a very good example of the happy relationship that we've had with people interested in those. It's interesting cluster headache with patient groups. None of the last three substantial things that have been done in studying cluster headache or acute therapies would have been done without your involvement, patient group involvement. So this is pretty standard way that things are done. I'll make a point of describing this because for reasons I'll explain in a second. So this is intranasal sumatriptan. I should say, I'm not sure I have to say, but I probably will say that not everything I say is uses that are FDA approved, and anyone who's looking at this should read whatever government rules there are. And I'm just telling you information. You know why I say things like that? It's like something I should say. Like, everyone read the book, please. Don't just run out and do this. Although this is all published, so it's not like it's dodgy or anything like that. So this is the first study we attempted. Actually, it's the second. This is with intranasal sumatriptan. 20 milligrams. You see this is the response rate. This is the pain-free rate. This is the placebo, and you see the active rate. So the little star means it works better than the placebo. 30 minutes. And intranasal sumatriptan's okay. Some people find it useful. I think the majority don't. But for those who do, that's probably simpler than making injections and easier than carrying oxygen around. But it's a small group. I want to draw your attention to the placebo. Placebo is quite important. The placebo effect that you measure in a clinical trial like this is a combination of a number of things. Firstly, it's a combination of natural history. Some attacks will be shorter than others, and they would have finished anyway, and you just got them, saw them, and you treated them late enough in the attack for natural history to get on. And you need to know that, because if you start doing a whole lot of studies without placebo, you get the idea that everything works. Because everything works for a little period of time, because that's the nature of the placebo effect. There are also some important mechanisms in the brain that tend to, that you can initially fool, if you want, into making change in any sort of pain problem, whether it's cluster headache, migraine, or any number of actually all the peripheral pain is well worked out. So this whole placebo notion, it's not craziness. It doesn't mean people don't. It shouldn't never be taken that when someone asks you to be in placebo-controlled trials, not that they don't believe you have a problem or they don't believe anything that's going on. What they're doing is that it's not about belief. It's about what you can prove to someone who doesn't believe anything. So it doesn't. You should never take it as an insult. That people who, if you're not doing placebo-controlled trials, you're almost wasting time with you, because you'll never convince anyone of just open-label things. It just doesn't work that way. You want to be able to go to any government body or anybody else with evidence that's so bomb-proof that they just lay down and talk about the implication of the evidence rather than the evidence is correct. It's a very important thing, I think. In IRBs, these review boards, are sometimes quite antsy difficult about placebos in acute headache studies, be it migraine studies or cluster studies. And I've always personally found it very important to engage patient groups in this discussion, because I think you're more qualified than the IRB to tell the IRB what's ethical for you to do there's far too much paternalism in medicine. It's not my job or the IRB's job to think whether you're smart enough to realise what the need of placebo is. I think it's very much a patient-driven thing. And I think you should drive people to do high-quality studies out of respect for your problem, not do half-baked studies and cut corners, because I don't think it shows any respect for your problem. There's a lot of paternalism in medicine like that. It's not very sensible. That's why I'm babbling about the placebo. This is the zolmitriptan, the two zolmitriptan studies. One was done in Europe, the other one was done in the US. The results are more or less identical. And you see two things which are important. One is that the outcome is better than placebo, and the second one is that there's a suggestion that it's dose dependent, which always means if you take more, if more is used, more patients get a response, and that tends to suggest the biological reality of what's going on. And of course this emphasises, all of these blue ones always emphasise that the small group of attacks, and this is a crossover study, so this is someone who's treated 3 attacks, and a small group of the proportion of the attacks responded just to the placebo, again because of time and all the things that I said. This sort of thing, the use of placebo really takes a study from the interesting to the really interesting, very, very quickly. The other one I wanted to mention is oxygen, which I have to say I'm particularly proud of. It took us 5 years to do this study. It was blocked at the start by the ethics committee, who were worried that the patients would blow themselves up because, yeah, that's what they said. Because they knew that they'd read somewhere that patients with cluster headaches smoke, and so they had this vision of sending gas bottles all around the country and people blowing themselves up all around the country and everyone being in a lot of trouble. Last time I said this, someone gave me an example of some chap in Texas who blew his car up by leaving the oxygen in the middle of summer sitting in the boot while he had lunch. I think some of the oxygen boot must have said that story. Personally, I've never looked after anyone who's blown themselves up with oxygen cluster headache. This goes to show you how silly sometimes the review. I understand review committees have an important job to do, but sometimes you just get a little overbearing, I think. So it took us a while to get this past the ethics. Eventually we got that done. And this study really showed, really stands out as a marker for what's possible. So it's a bit of a folklore in clinical trial work in headache that crossover studies don't work. So what are crossovers? There's 2 sort of studies you can do. If you want to show something works, you can do a parallel group study. So you take say 100 people, and 50 get air and 50 get oxygen, and you compare the response. Or you can do what's called a crossover. So you take all 100 and they treat 2 attacks. On the first, and it's randomised and they don't know which is which. So they treat an air attack with air, and attack with oxygen, or vice versa. Now, it's said in the little bit of the medical folklore that crossover studies don't work because patients don't complete the crossover. This study showed that's just nonsense, because the vast majority of patients in this, we only had 2 people who didn't complete the crossover. 2 out of 76, that's not too bad. That's within the range. Some didn't complete it because they had episodic cluster headache and they went out of the bout. But that's fair. That's biology. I mean, you can't call anything for that. What this study shows is that crossover studies are possible with cluster headache, and indeed they're attractive. This was a 4-attack study, 2-armed, air, oxygen, air, randomised and controlled and blinded. So the result's pretty much bomb-proof. That's what I mean. Apart from blowing up the oxygen, of course, it's pretty much bomb-proof because you've got repeated attacks. You can look at reliability. You can compare the placebo. Again, look at about 20% of the response to oxygen, which is in the high 70s. And the difference, you don't have to have a lot of statistical ability to understand that those are distinctly different outcomes. And with a relatively small number of people. We probably overpowered this 76 patients, 278 attacks. I mean, it's probably we probably overreacted at some level. I have to say,